Well, hello, colleagues. My name is Sanjay Popat. I'm a consultant medical oncologist at the Royal Marsden Hospital and Professor of Thoracic Oncology at the Institute of Cancer Research, both in London in the UK. And today I'm going to be speaking to you about mesothelioma, its epidemiology, diagnosis, staging, and prognostic factors as part of this EUROCAN Moodle. So these are my disclosures. So let's talk about the epidemiology of mesothelioma. Well, what is mesothelioma and where does it arise? Well, mesothelioma is a malignancy of the mesothelium, and that asks you, what is the mesothelium? Well, it's a cell monolayer lining the body's serosal cavities and internal organs, specifically pleura, the pericardium, the peritoneum, and tunica vaginalis. It's derived from mesoderm and expresses both mesenchymal and epithelial markers. It's slowly renewing tissue with between 0.16 and 0.5% of cells undergoing mitosis at any one time, and its primary function is protective. It lines non-adhesive surfaces, and it has a role additionally in antigen presentation, inflammation, and in tissue repair. So where does mesothelioma occur in the body? Well, it occurs anywhere where you find mesothelium, but predominantly in the pleura. And in fact, pleural cases of mesothelioma account for nearly 95% of what we see. However, it can occur and arise in the pericardium, the peritoneum, and the tunica vaginalis. So how common is mesothelioma? Well, given this is a EUROCAN recording, it's rare. Its age standardized rate, ASR, globally is 0.3 per 100,000 persons. Then it's more frequent in males at 0.46 than it is in females at 0.17. And if you look at the map on the right-hand side of the slide, you can see that there's not only a difference in frequency between males and females, but you can see that there's wide geographical distribution globally, with an intense number of cases occurring in North America, England, mainland Europe, Scandinavia, South Africa, and also Australia. And why is this distribution that we see in terms of cases? It's fundamentally due to the cause of mesothelioma, which is specifically asbestos exposure. Here you see scanning electron micrographs of the two major types of asbestos, white asbestos on the left, chrysotile asbestos, and amphibole asbestos, the blue and brown asbestos on the right-hand side. So what is asbestos? Asbestos is a group of terms which describe a number of silicated minerals. These minerals are naturally occurring fibrous minerals which occur in the ground and are mined for their properties. They are very, very good insulators. And what are the specific types of asbestos? Well, asbestos is just a generic term. We have the serpentine group of minerals called chrysotile, which is commonly called white asbestos. And then we have the amphibole group of minerals, of which there are two commercial types which have been mined, which are called chrysotile and amosite, or specifically blue asbestos and brown asbestos. But there are a number of other non-regulated fibrous materials associated with asbestosis, cancer, and mesothelioma, all diseases caused by exposure to asbestos. Alongside the regulated fibrous minerals, we have the non-regulated fibrous minerals in the classes of serpentines, amphiboles, gagiites, wollastonite, zeolites, etc. Specifically, erionite is a non-regulated fibrous mineral which occurs extremely commonly in several parts of the world, including certain regions in Turkey, and is associated with outbreaks of mesothelioma in certain areas there. And there is a call, for example, for greater regulation of these non-regulated fibrous minerals than currently we have. So how does asbestos biologically cause mesothelioma? Well, you have the normal mesothelial cells that you can see in the top left, and then these are then infiltrated with asbestos fibers. These are spike-like mineral fibers, which go into the mesothelial cells, attract macrophages because they cannot be destroyed by the cells. Macrophages come along trying to cause phagocytosis, release cytokines, and we see an inflammatory response in the bottom right. This inflammatory response occurs in the mesothelial cells and induces chronic inflammation with infiltration of T regulatory cells, and very, very gradually over many years results in chronic inflammation transforming into invasive malignancy. Indeed, the lag time between asbestos exposure and mesothelioma presentation ranges between 20 to 40 years, or so, depending on several cases. So there's a long lag time. So how was or is asbestos still used? Well, fundamentally, it's an insulator, which is why it's been used in commercial use as well as domestic use. It's been mixed with plaster, in pipe lagging, mixed with cement, used with plastics, sprayed in coatings, and used in insulation board, typically asbestos insulation board. And you can see photographs of all different types of minerals, so photographs of all different types of uses of asbestos that have occurred over the years and are now prohibited in many parts of the world. Well, is asbestos still mined? Yes, unfortunately, globally it is still mined, and therefore there's an ongoing global problem with the future of asbestos-related diseases, and specifically mesothelioma. When we look at this particular example publication of the numbers of million metric tons mined, we see that there's been a big reduction in the numbers of million metric tons mined over the last 20 years or so, but still there is a reasonable amount of worldwide production of usage from the US Geological Survey. So which countries are still mining it? Well, Russia, Kazakhstan, Brazil, and China are by far the biggest miners of asbestos in the modern era, and these are 2023 data. So if those countries are mining it, who is it used by? Where is it exported to? Is it used in those countries? So if we look at who still uses asbestos, well, we can see the biggest users are India, Brazil, and China, with a number of other countries using it at a small scale. Of course, many of these countries don't only use it for the domestic market, but they also export products to the rest of the world, and these products are sometimes used internally as well. There's an ongoing issue with regulation of asbestos and its products and usage outside countries where this would normally not be expected. And if we look at asbestos usage over time, this graph taken from a policy document demonstrates the numbers of decades that asbestos has been used by several countries. We can see for countries such as Bulgaria, Estonia, Latvia, and Lithuania, usage of asbestos has mainly been in the later decades, 1981 to 1990, for example, or 1970 to 1980. However, when we look at the more Western European countries such as Germany, Spain, and Italy, usage of asbestos has been fairly even, dating back until the 1920s and 1940s, 50s, and 60s, with less usage in the modern era. Therefore, we can see that the total asbestos consumption in recent years spiked in about 1970 and then has gradually reduced over these years as we've become more aware of the risks of this mineral. But of course, this means that many countries in Europe have significant asbestos usage. In this graph, you can see the amount of asbestos consumption in tons between the period 1920 and 2017, demonstrating Germany, Italy, France, Great Britain, Poland, Spain, Czechia, Belgium, etc., have significant usage of asbestos over many years, as I've said previously, resulting in quite a significant exposure of the population to asbestos and therefore incidence of asbestos-related diseases such as mesothelioma. Indeed, one of the biggest problems we have in Europe is that asbestos, particularly white asbestos, has been mixed with many products such as cement and plastic and used in homes as domestic insulation. And this is particularly a problem looking at the graph on the right, where we can see the blue colors represent high usage of asbestos in young or new dwellings. This is particularly problematic in Eastern Europe and in Western Europe, we have problems with high usage of asbestos in older buildings. And this becomes a particular problem when trying to dispose of these properties in a safe manner. Indeed, when we look at the history of asbestos use and its prohibition, it was first associated with disease in England in 1924 when W.E. Cook published the first paper on asbestos-related disease. Thomas Oliver coined the term asbestosis of pulmonary fibrosis in 1925, and the inspector of factories, Edward Merriweather, confirmed that inhalation of asbestos dust caused fatal disease back in 1930. Sir Richard Doll in 1955 identified that asbestos workers had a significantly higher risk of contracting lung cancer compared to the rest of the population, and only in 1960 did Wagner and others publish their first paper demonstrating a relationship between pleural mesothelioma and asbestos exposure, and that then prompted prohibition in many countries around the world. However, when we look at the history of prohibition of asbestos in many countries around the world, look at the year of bans in the x-axis for all the different countries. Final prohibition has only come in very, very recent times. Great Britain, for example, in the late 1990s. And if you plot that against the per capita asbestos consumption, you can see there's a big problem still ongoing with asbestos likely exposure and definite exposure in many parts of Europe. But of course, we also see the unusual scenario of familial mesothelioma. And here we know that germline BAP1 mutations, patients that are born with germline BAP1 mutations, are more predisposed to mesothelioma. And this is as part of a BAP1 related cancer predisposition syndrome. This paper here demonstrates two families, family W and family L, where mesothelioma and many other tumors seem to be heritable and associated in the family. And indeed, with further work, we know that there are a number of tumors associated with germline BAP1 mutations, specifically uveal melanoma, cutaneous melanoma, renal cell carcinoma, potentially cholangiocarcinoma, basal cell carcinomas, but a very unusual type of atypical M-BAP nevi, melanocytic BAP1 associated intradermal tumors. So whenever we have patients with these types of nevi or these types of tumors, we need to be considering the family history and whether it's associated with a wider cancer predisposition syndrome, including pleural mesothelioma. So how does one make a diagnosis of mesothelioma? Well, patients present in a number of different ways, as you'd expect, but predominantly breathlessness or cough, often with respiratory distress, often with pain due to tumor infiltration, and the constitutional effects of having a high disease burden, including weight loss, cachexia, and night sweats. Fundamentally, because of infiltration of the pleura, the pleural fluid builds up and is no longer easily reabsorbed by the pleural surfaces, leading to a large buildup of pleural effusion and collapse of the underlying lung. So what are the investigations that should be undertaken to make a diagnosis? Well, one should always take a good history, documenting the respiratory system, pain, weight loss, night sweats. If suspecting mesothelioma, it's absolutely critical to take occupational history. Has the patient been potentially exposed to asbestos or not? And particularly noting the link between family syndromes of malignancy. Is there a family history of malignancy? What are the malignancies? And the role of a family history of mesothelioma. Of course, we should take a physical examination, document the respiratory status, note whether effusion is present or absent, and note the differential diagnoses. Patients presenting with pain, weight loss, and malignant effusions may have malignancy other than mesothelioma, and in fact usually do. For example, metastatic adenocarcinoma of the lung, breast, colon, or ovary presenting with malignant pleural effusions. Benign causes of pleural effusions need to be considered alongside fibrotic lung disease. Patients should have comprehensive routine blood work, including full blood count, assessment of electrolytes, including renal and liver function, and also undergo a baseline chest. Well, what about staging? How do we work out how much cancer the patient has on board? Well, CT is the workhorse of these, and CT is really what all patients should have. Patients should undergo a CT of the thorax and full abdomen to include the bases of the pleura, and perhaps one may, in the modern era, want to consider including the pelvis as well, if there's concern about peritoneal involvement. The CT should be done with contrast, and the contrast should be administered in the portal venous phase to better highlight the pleura to be able to work out whether there is pleural thickening. We should be able to identify the pleural thickening occurring within one hemithorax and ideally see whether any of the local regional nodes are involved, see and assess if there is invasion of the chest wall or the mediastinal structures or the diaphragm. Asbestos particularly likes to go to the inferior surfaces around the diaphragm, and these are where we often see large plaques of mesothelioma developing. We need to check the abdomen for involvement, particularly peritoneal thickening, the mental stranding, the mental thickening, and indeed the presence of ascites. And of course, we know that CT, whilst brilliant, is really quite a poor workhorse in documenting the amount of disease that we have on board, because it's quite difficult to sometimes see pleural thickening against the normal chest wall background. And indeed, there's often a discrepancy between what's found at time of surgery, if the patient does go down surgery, to the amount of extensive involvement on CT. Now, how do we stage mesothelioma? We use the UICC TNM staging, and here we have 4 levels of primary tumor infiltration, T1, 2, 3, or 4. The greater the number reflecting, the more the invasion of the pleura, the chest wall, the larger structures, including the vertebra, neuroforamen, spinal cord for T4, and the local regional lymph nodes being involved as N1, with N2 representing metastases to contralateral intrathoracic lymph nodes. There is no N3 status in mesothelioma staging. Distant metastases are uncommon generally in mesothelioma and are staged as M0 and M1, and we have all the different stage groupings, T and N and M, to result in the different stage groupings you can see in the bottom right-hand side of the panel. Well, what about the role of PET? Should we be using FDG PET? Well, PET is traditionally used in cancer to identify occult metastatic disease. And here in mesothelioma, the issue is that the likelihood of metastases are actually low. So the probability of finding this occult metastatic disease is really very low in the first place. It may help in identifying occult nodal disease. But if your lymph nodes are involved, does that really make a difference to your treatment strategy? Well, it may do if you're considering surgery for the patient, but PET is well associated with false positives and false negatives, so we need to be careful about this. We often have to remember that these patients will have had some sort of talc pleurodesis, and talc pleurodesis results in an inflammatory reaction, and that can result in avidity around the pleura for many months, if not years, in patients that have had talc pleurodesis. And PET may not be required for every single patient, but it could be recommended if considering surgical resection. In fact, many of the guidelines do recommend PET if considering surgical resection. So how do we make a diagnosis of mesothelioma? Well, thoracoscopy is the gold standard and should be considered. Ideally through surgical thoracoscopy, through VAT surgery, or if unfit, through medical thoracoscopy. This is absolutely critical because not only does it allow drainage of the effusion, but it allows visual inspection of the pleura and therefore staging, and importantly, large biopsies to be taken. To identify mesothelioma as a diagnosis, the malignant tumor has to infiltrate across the basement membrane, and that is only possible with large, good quality biopsies. Thoracoscopy also allows talc pleurodesis to control the effusion, and in some cases where the lung is trapped and does not re-expand after drainage of the effusion, indwelling pleural catheter can be considered if required. Is invasive staging required? Do patients require endobronchial ultrasound or VAT surgery to stage the mediastinum and the mediastinal lymph nodes? Well, it only should be undertaken if it makes a difference to how you're going to manage the patient, i.e., if you're determining whether the patient is operable or inoperable on the basis of the results. So, according to ESMO guidelines, basic staging in all patients includes CT, thorax, and upper abdomen. And in those patients where we're thinking about multimodality treatment with surgery, those patients may be considered for FDG PET and perhaps EBUS or EUS if we're wanting to exclude patients on the basis of definitive lymph node involvement. And in those that we're considering surgery who have borderline resectability, we may want to be considering more extensive staging, including laparoscopy or contralateral VATS, mediastinoscopy, or MRI brain, or other areas if we are concerned that they are infiltrated. Well, what about other prognostic factors other than staging? What do we consider when we are managing our patients with mesothelioma? Well, why do we need prognostic factors? Well, we need these to better predict outcome, to better understand the natural history of disease, to better predict the right treatments that we want to use for the right patient. Is surgery worthwhile? Well, we may not want to offer this to a poor prognostic patient, but a good prognostic patient. Is radical radiotherapy worthwhile? The same considerations apply. And in many respects, we have to consider this also for optimal drug decision making. It's absolutely critical to prognosticate accurately for clinical trial design because we need to minimize the hidden covariates that impact on survival to result in balanced groups and have no hidden imbalances in these prognostic variables. So what are the main variables that we use? Well, ECOG performance status that you can see graded 0, 1, 2, 3, or 4 is by far the most significant prognostic status. There are many old studies demonstrating this. For example, in the right-hand side here, the Dana-Farber Cancer Institute registry confirming that good performance status 0 does way better in the solid line than performance status 2 or worse, the dashed line, doing very, very poorly in all patients with mesothelioma. Gender plays a large role as well. We know that men tend to get mesothelioma more commonly than women. That's because men have worked in the industries more associated with asbestos exposure, and females have tended to work less in these industries. And we know that men may perhaps have a higher mesothelioma disease burden attributable to the asbestos exposure, and men in general have a poorer prognosis. You can see here from the Western Australia Mesothelioma Registry and many other data sets support this than females. Important, therefore, to ensure that we have balanced data sets. Histological subtype is also very critical. We know that there are different histological subtypes of mesothelioma, broadly speaking, epithelioid, sarcomatoid, and a mixed group called biphasic. And we can see here from the Western Australian Mesothelioma Registry here that epithelioid by far has the best survival prognostically compared to sarcomatoid, and the dotted line doing very poorly indeed. But we can be even more complex and work out prognostic scores. Here, the EORTC group has calculated a prognostic score for mesothelioma, which has been independently verified by many other groups. Here we have prognosis based on the white cell count, performance status, histological diagnosis, subtype, and gender. And we have good prognosis mesothelioma and poor prognosis mesothelioma contingent on the number of prognostic factors identifiable, weighing on the fact that CT scanning, whilst possible, and we have a TNM strategy for mesothelioma, may be inaccurate and not give us the best function of prognosis when treating this disease. Our American colleagues at the CALGB have also come up with a more complex prognostic score with 6 different groups here based on performance status, age, hemoglobin, white cell count, chest pain, and weight loss factors, with different groups according to different prognosis. Again, this has been validated in many, many different prospective and retrospective. And in the modern era, we are now doing genomics on patients and genomics on their tumour. And we know that patients with germline BAP1 and other mutations tend to be associated with a better survival compared to those patients without. And whilst genetic testing may not be standard at this time in 2023, it may become standard in future years and needs to be given some consideration when considering prognosis. And with that, I'd like to thank you for your attention and hope you found this Moodle lecture of some value. Thank you.